Thank you so much, Mari, for starting us off. I'm going to now go through the research that we did on clinicians' perspectives and experiences of providing cervical ripening at home or in hospital. And I'm not going to give an overview of what we did because Mari already did that, and I'm going to be giving quite a brief summary of the findings. But again, this is in our preprint, so if you are interested in more detail, it can be found there. So just a little bit about the background and aim for this part of the research. So the offer and practice of home cervical ripening is inconsistent both within and between institutions. And this is something that we found as part of a survey that we did during the COVID-19 pandemic. See reference there. And there's also a paucity of literature on clinicians' experiences of providing induction of labor in general, despite their central role in developing guidelines and delivering this care. There's also very little research on different approaches to cervical ripening in practice and on the safety and acceptability of home cervical ripening, which is why we were doing the choice study. So the aim of this was to explore induction of labor, specifically cervical ripening, and the option to return home during that process from the perspectives of midwives, obstetricians, and other maternity staff. So just a little bit about the method and analysis, which I know Mari really gave a good introduction about. So this data comes from semi-structured interviews and focus groups that were conducted with clinicians working in the 5 Q-choice sites, case study sites in England and Scotland. And all interviews and focus groups were conducted by myself, Mari, and our colleague Clarice Wallace between November 2020 and December 2021. So we were doing this research, as Mari said, during some of the heights of the COVID pandemic. So first I'm going to go through the descriptive findings. So in all, we did 48 interviews, and you can see the numbers on the side there, and 4 focus groups. We had a total of 76 participants in all, and we had a lot of midwives, obstetricians, and some other NHS staff, as well as stakeholders. So we found that all 5, so part of this research, we did ask about policies, induction of labor policies at each of the 5 sites. So all 5 of the case study sites provided home cervical ripening. A lot of local policies changed due to COVID-19 restrictions, with one site suspending the service for majority of the study time. And the policies for induction varied between sites, which is consistent with our survey that we did on practice changes during COVID-19. I have a table here just sort of outlining some more details about all of the 5 case study sites. As we said, I know it might be hard to read. We have a much longer, much more detailed paper in the preprint if you are interested in looking at this a bit more. But there was a lot of variation in the methods used for cervical ripening, specifically home cervical ripening, which Mario has been mentioning earlier. So some used Dilapan, some used a balloon catheter. One of our sites even used prostaglandin for home, and there was a lot of variation between, who was being offered to go home, as well as the eligibility criteria for going home too as well. Okay, so now I'm going to move on to the thematic findings. So the thematic findings were generated through an in-depth analysis of the interviews and focus groups, and are grouped to reflect the induction of key points along the induction of labor process, specifically when you're providing induction of labor, specifically cervical ripening care. So the first one is implementing home cervical ripening, putting local policy into practice, giving information about induction, and providing cervical ripening. Okay, so most clinicians who took part were positive about cervical ripening. Most perceived it to be better for themselves in terms of managing maternity workload, and also for women and their families, especially those who were deemed low risk and healthy. However, the use of home cervical ripening, as I said, varied between sites, and many were not offering home cervical ripening widely in practice. Some of the motivations for introducing home cervical ripening were stated as reducing unnecessary time in the hospital for women, linked to the perception that women would prefer to be at home and that their experience would be improved by offering home cervical ripening. And significant groundwork, such as knowledge building, cross-boundary collaboration, and confidence were all cited as key for implementing it. And the next quote I have sort of shows what happens when these sorts of things break down. So this midwife is talking about how women were being given the proper information about home cervical ripening, and so they weren't keen for it. And they're talking about how if one element in this chain is not performed, then it impacts the way that this is implemented across the entire service. Okay, so putting local policy into practice. So participants, as I said before, were asked about their local induction of labor policy or guidelines during interviews and focus groups, which revealed these intricate care pathways involving many different actors and places. And I know it's going to be really hard to see, but the figure on the right details the sort of the flow of this care pathway. And it's based on an interview that I did with an obstetrician. And you can just see all of the different things that happen during this care pathway and the different places that this involves, as well as where some of the delays occur. So induction of labor policy dissemination was described as uneven and difficult to access. Induction of labor was typically offered and booked by midwives for those who deemed low risk and by obstetricians for those who were deemed high risk. And midwives were expected to take on new roles with home cervical ripening, including inserting catheters or the osmotic dilators, and as well as the logistics of managing women both in hospital and at home. So this midwife is talking about just some of that setup, some of that groundwork and getting this policy into practice, talking about providing training for midwives because they wanted this service to be midwifery-led, and the challenges that you face as a midwife when you're trying to set that up and to doing this induction of labor procedure, and the challenges for women going through that induction procedure, and talking about how keen they were to get this up and running and having the guidelines all set, again, doing all that groundwork, and then having the impact of the pandemic on staffing, and that really impacting their ability to do outpatient induction of labor or the home and cervical ripening. And as we said, we did see impact from COVID during this study, of course. Okay, so moving on to about giving information about induction. So participants often spoke of a mismatch in perspectives between themselves and those undergoing induction of labor. Managing expectations using realistic information about induction of labor was viewed as crucial for closing this gap. But time and resource constraints, such as tools and evidence, were identified as obstacles to effective information giving and risk communication. And I've just got some quotes to illustrate this here. The first comes from a midwife talking about the lack of time that community midwives have. They have a 20-minute appointment. They have to do the normal antenatal check, and then you have to discuss induction of labor with them. And this is obviously, as we saw that earlier figure, the flow, the sort of induction of labor is quite a complex thing to discuss, and that's really that limited amount of time. And then this next quote comes from an obstetrician talking about the lack of tools to have this discussion, having infographics, not having anything in different languages other than English to help people understand this complex process, as well as the lack of evidence that gives this sort of induction of labor process this uncertainty about it too as well in terms of giving information. Okay, so finally, I'm going to talk about providing cervical ripening. And I know Mairi has also detailed quite a little bit about, the context of which people were undergoing cervical ripening, as well as now providing that care. Delays were an issue throughout the induction of labor process, frequently occurring between the cervical ripening procedure and admission to labor ward for ARM, as Mairi has talked about. Participants and clinicians in this part of the study attributed delays to inadequate staffing, while some suggested home cervical ripening would create its own set of logistical issues. Most believe that it would be a solution to the delays and dissatisfaction with the induction of labor process. There were conflicting views on the impact of home cervical ripening on workload. Some felt it made workload easier to manage, while others did not. And I've just got a couple of quotes here. They're quite long, so I won't go into them in detail, but this midwife talking about ringing women on a waiting list to come in for their cervical ripening at 1:00 in the morning, at 3:00 in the morning, to bring them in, and talking about this process, this system of going down this list, of having, when they have capacity, ringing women in the middle of the night several times, documenting it, moving on to the next one. And if no pickup, moving on to the next one, and just doing that until you get every single one in. And again, this is, this extra administrative workload connected to this. And then finally, from this midwife, talking about the challenges, particularly, and the risks that could even be associated with the current staffing levels at the moment. Again, only being able to get a woman to a certain point in the induction process, and if there's no midwife available to give them the one-to-one care in labor ward, to be able to break their waters and get on with it, because obviously once that's done, they have to look after them. And if they don't have the staff, that's when you end up with this delay. And so talking about, not being uncommon to see these delays for 24 hours, and the many women just sitting on the wards, just waiting for something to happen. And also, talking about being aware of the fact that with the staffing levels the way that they are, because the staffing shortages were even apparent, obviously, during COVID, and after sort of the levels of COVID started to reduce too as well, there were still issues with the staffing levels, would not really completely remove that risk by doing outpatient induction or the home cervical ripening. Moving on to the discussion. So implementation of home cervical ripening varies across the NHS, given the uncertainties that surround it, including gaps in the evidence and unpredictable nature of maternity care work. A range of practices and views on induction of labor were recorded, and we've got more in the preprint and the paper if you want to look at that, particularly around the methods used, showing how the integration of home cervical ripening is not always straightforward, and how deviations from local guidelines might occur when put into practice. So home cervical ripening appears to be about improving women's experiences, but is also strongly linked to workload. It was largely seen as a solution to operational challenges of induction of labor care. However, this perspective is based on underdeveloped and at present inconclusive evidence about the safety and efficacy of home cervical ripening and the impact on workloads and resources. Participants were often looking for strategies to manage workload, and home cervical ripening was one proposed solution. Yet they highlight the ways in which this expectation might not be borne out in practice. Home cervical ripening did not necessarily lessen workload, but rather shifted it from one space or person to another, and in some cases increased it. So our findings also highlighted the service's limited preparation for increased induction of labor rates in terms of workload changes and additional staff time and stress. And throughout the induction of labor process, from giving information to providing cervical ripening, time was limited and delays were frequent. Clinicians reported efforts to keep the process moving, even if this meant calling women repeatedly in the middle of the night when staff and space became available. So this process production approach to care responds to the pressure on staff and services. And this process production approach is sort of, something that we talk about, sort of that more industrialized model of approach to healthcare. So it responds to the pressure on staff and services, but disregards the well-being of women physically and psychologically, as Mairi has detailed in her discussion, in her talk. And so women need to fit the system, or they miss out, passed over for the next person on the list. This approach sits in opposition, in our view, to national maternity policy ideals of person-centered and compassionate care. However, it was a way for staff to cope with the unmanageable workload connected to increasing induction of labor rates. So this process production approach, coupled with expectations of home cervical ripening, are indicative of a trend, in our view, towards routinization of induction of labor in maternity care. Induction of labor, as we argue, is not without lateral effects and represents a significant workload in the UK maternity services, which are currently experiencing acute staffing shortages. And in light of this, we argue making induction of labor more routine, whether at home or in hospital, should be reconsidered, and its potential risks, including unintended effects and those beyond the usually recognized clinical scope, require further scrutiny. Home cervical ripening is not necessarily a solution. Thank you so much. This is the link to our survey, the preprint, and as well as to our survey that we undertook during the COVID-19 pandemic. Thank you so much.